All right, so I want to put in a plug for a new student club that we're starting. So I know you've probably been inundated and heard, you know, about like 100 different clubs or something, but this one is going to be among the better clubs, I think. So, one of the best, yeah. So Nora, sitting up here in the front, Gabe and I are starting it, and it's called Students for a National Health Program. And what it is it's going to be the student club version of what Dr. Weisbart's going to talk about. So it's going to be a brand new club this year, and we're going to advocate for and educate regarding single-payer health system. So about halfway through the talk, we're going to circulate these sign-up sheets where they're going to be for if you want more information regarding physicians for a national health program. Right at they're modified sheets. So right at the little end, there's this imaginary box. You can imagine a box. If you want information regarding this club, just check right there. Just a little check. So we had to modify it. So if you want information, check there, and we will look forward to getting our first few events going here soon. Anyway, thank you very much.
We're going to remind you about this when we circulate these. Okay. Well, again, not much for microphones. Maybe this will be a little better. Hello? Okay. So to give a little bit more background on Dr. Weisbart, Dr. Weisbart did his MD at the University of Illinois in Chicago. After that, he did his family medicine residency, family medicine, at Michigan State, as well as a fellowship in family medicine education, which actually I don't know much about. We maybe talk about that at some point. He worked for over 20 years at the Rush Medical Center in Chicago as a family physician. And then he took a job in 2003 working for Express Scripts as their chief medical officer. He was there for 7 years, but more importantly for us, that brought him to St. Louis, and he has not left. So we are really excited to have him here. Should mention, too, he is currently on the faculty at WashU. He's an assistant professor of clinical medicine here. He is, as I said before, he's heavily involved in issues around healthcare, especially for the underinsured and uninsured. He works with the Regional Health Commission. That's how he and I crossed paths this summer, and is very involved in free clinics in St. Louis and in the larger country. He's written extensively about healthcare and is published in a bunch of national medical journals as well as local periodicals, and he really is a renowned expert on healthcare, especially as it is changing and how those changes are affecting the uninsured and the uninsured. So it is my great privilege to introduce Dr. Ed Weisbart.
Hello. So with that, I don't know how I can live up to that. So, it's a treat being here with you all. I just spend the first 10 seconds usually, it's something like this, basking in the pleasure of seeing all of you. I remember a presentation at the very beginning of my medical school life that transformed the way I thought about healthcare and such. So if I can get a tiny chance to pay that back. And it turns out the speaker that gave me that presentation was 2 years ahead in a different medical school, and I never saw him again until I joined this organization, Physicians for a National Health Program, where he had wandered off to for years. So anyway, I'm glad to be here. We're going to talk about how, as you heard, about how healthcare works in the United States a bit. Some of that will be information that you're probably already familiar with, but in a different context. And some of that will be brand new information that you haven't seen before, I'm pretty sure. And I know that because I made it up today. So, you know, you'll know. I'm teasing about that because all of my slides that have numbers on them will have a footnote in the bottom left-hand corner, which you won't be able to read. It'll be too small. But if you really want to know the source of the data, I have it right here, and I can tell you who said what I'm saying is said. So we'll talk about how healthcare works. We'll talk a little bit about what's changing under the Affordable Care Act, and then we'll take a pause, and we'll do what you heard. You know, we'll pass out these sign-up sheets, because if you want to remain engaged in this kind of discussion, we'd love to be able to stay in touch with you, mainly through email, I guess. So there's that. And then we'll go into, obviously, the reason that I'm here, which is to talk to you about what I think makes more sense as a healthcare system. So my background, as you heard, has been heavily in medicine, right? I practiced for 20-some years, delivering babies, taking care of old folks, and doing the ICU work and central venous nutrition and everything, because they weren't hospitalists. So did all that sort of stuff for 20 years. And I continue in the Center for Outpatient Health, supervising the internal medicine residents at least once a week, and then all kinds of other stuff. So my core, of course, is about medicine, which is sort of like where your core is these days. But I've had quite a bit of time in the business world as well, as you heard by through the Express Scripts. We can talk about that later if you want. So part of the message here is no matter what you think about the topic, I want to convince you that you are embarking on a career that has tremendous flexibility, and you can do all kinds of different things, most of which you probably can't begin to anticipate. So keep your eyes open. There's all kinds of stuff. But my career has been heavily in business, too, so you'll see that a lot of the arguments I'm going to be presenting to you will be based on information that's more economic than clinical, because I think we probably already kind of get the clinical side of this. But so there's that. The organization, as you heard about, is Physicians for a National Health Program. We're all volunteers. I'm not paid for being here. You guys are paying to be here, I guess. So we're all volunteers. There's a lot of us around the country. We started the chapter. We have one basic mission, which is to get health care to everybody, and we think the way to do it is by improving Medicare and giving that to all, but we'll talk more about that. We started here in St. Louis about 3 years ago, and we now do lots of presentations to all kinds of groups, ELK clubs, Rotary clubs, certainly medical staffs, and others. So that's what we do. So to open, let me just point out that we American physicians are among the least happy physicians in the world. So there we are, not so happy. German physicians are less happy. I don't know why. It's Germany. I don't know. I don't know much about that. But we'll come back to this, because I believe that what we're suggesting is going to a certain degree, mitigate that and maybe really reverse that. So I got connected to this through, as you kind of heard, through the free clinic movement. That was one of my first real sort of involved things. This is a picture from the National Association of Free and Charitable Clinics. They sponsor, or they support the 1,600 or so free clinics around the country, and they host these one-day massive free clinics in different cities. They've done 15, I think, and I've been at, I think, 11 of them as a volunteer. So they rent out the big convention hall in town, and they bring in volunteers, and 1,000 people or 1,500 or 2,000 people without insurance line up and wait sometimes a few hours to get free primary care, some specialty care, on-site testing. They get mailed 4 months of medications, and they get connected to aftercare. So that's what they look like. I'm pointing this out because they look like you and me. Well, they don't have ties on, but I don't usually either. I mean, they're dressed up. They're normal-looking folks. 83% come from households where somebody works full-time. So we also get lots of volunteers, as you can see. And the volunteers, 2/3 of them for this particular event. The message on these volunteers is that when I started doing this, I thought they were all going to be politically like-minded to me, whatever that meant. That's not the case. That's not the case. We tend to think that the country is MSNBC watchers and Fox News watchers. The country's red and blue, and that the people that don't agree with us, we demonize them. We think they're cold-hearted or stupid or ignorant or something. And we say the same things about the other side that the other side says about us, no matter who you are. Because at our core, human beings want to help each other. These volunteers come from every faith or non-faith. They come from every political party. They come from every socioeconomic. They're not demons. The people with whom we disagree are not evil. This isn't good versus evil. This is we all, human beings, want to do the right thing. We just disagree about the tactics and the strategy and what exactly that is. But we are all, even if you leave here disagreeing with the message I'm trying to deliver, just have this information at least. So anyway, who comes to these clinics? Here's a mix of the ages of people that come to these events. So there's little kids, there's older folks. You can see not so many kids, right? And here's the age mix of people that go to see the doctor around the country from a Medical Group Management Association, I think it is. So that's, they're different, right? And why are they different? It's a pretty obvious reason, because for kids, we have an imperfect but pretty good solution called CHIP, Children's Health Insurance Program. So most kids don't really need to wait in line at the mercy of a free clinic, although some do. And we have the similar imperfect but pretty good solution for seniors. So our policy decisions matter. So how are we doing as a country? Here's life expectancy, probably something that you've run into before. And there's us at the end. These are all countries that live longer than us by this data set from the CIA World Fact Book, word number 51. This slide's about a year and a half out of date. I noticed it's a little bit different when I looked last night, but I didn't change it yet. So anyway, those countries all live longer than us. You probably knew that, sort of, right? I'll bet you didn't know this. Here's a different way to look at the data, stratified by age, and United States life expectancy at birth, or United States life expectancy at that age, right? Compared to, I think, 17 other modern nations. So obviously, if you're ranking 17 for 10-year-olds, you're the worst of life expectancies for 10-year-olds among these 17 nations. So how does the USA perform? Not so well. Not so well. We're the bottom, actually, of these 17 nations until you hit age 65. Did you know that? Did you know, you knew that we had trouble with life expectancy. You knew that, that's an issue, but it's complicated. Is it handguns? What is it? You knew that. But did you know that once you give Americans Medicare, it transforms? And we don't quite hit number one, but we come pretty darn close. So you know that we have millions of people without insurance. Despite that, we still spend double what any other country, modern nation, spends. So there we are on the red. We're spending roughly $9,000 per person per year compared to roughly half that for almost any other modern nation. So why is that? Why do we spend so much? Is it because we go to the doctor so much? Well, I submit to you it's these two things. It's that our prices are too high and that our system is too complex. And I'll show you some data about this. Our prices and our system. Not so much utilization, and I'll show you some data about that. So prices. What's wrong with her? Why is she sitting there in front of a fan? What? It's a medical bill she got. I like that. Yeah, no. Obviously, it's a middle-aged woman who's having a hot flash, right? So it's the funniest darn thing. I show this slide to all kinds of audiences. The Rotary clubs all get it. And never in a medical school group does somebody say it's menopause. It's just the darndest thing. Undergraduates last week got it in one. You guys probably don't want to say the obvious because you're used to being tricked by it and pimped. So anyway, why am I showing you a picture of somebody in menopause? Because there's a new drug on the market. It's been out for, I don't know, a year and a half, 2 years, called Brisdell. Have you heard of Brisdell? Good. So what is Brisdell? It is the first and only FDA-approved drug for the treatment of symptoms of menopause, hot flashes. Hooray. I mean, hot flashes come in small, medium, and large, and small can be so trivial that, oh, that was that, that you don't even care. But they can be actually nearly disabling. They can be so severe. So a drug for this is, I think, a good thing. So what is this groundbreaking drug that pioneered by the American medical pharmaceutical industry? What is this drug? It's paroxetine. 7.5 milligrams of paroxetine. Have you ever heard of paroxetine before? Paroxetine is the exact same chemical that was in Paxil. Have you heard of Paxil before? Paxil is one of these groups of antidepressants that came out about 25 years ago or so. Paxil, Prozac, Zoloft, there's, I don't know, about 12 of these, I think. Anyway, it's been out for like 25 years, so it's available generically. Paxil, when used for depression, was prescribed in 5, 10, 20, 40, 80 milligram dosing. Okay. Brisdell is only marketed as 7.5 milligram dosing. There's no clinical difference between 7.5 and 10 or 7.5. There's, it's not a clinical difference. But the difference, of course, is that Paxil is available generically. So if I write a prescription for Paxil, and I don't check do not substitute, which, why would I? If I write a prescription for Paxil, 10 milligrams, the pharmacist will dispense paroxetine, the generic equivalent, without calling me because they're identical. So they can do that. If I write for Brisdell, again, the same exact chemical agent, but a tiny difference in dosing, they have to dispense the brand unless they call me for a substitution. And they don't want to call me. You don't want to call your doctor. It's too hard. So they want not to. Okay, so Paxil, I just told you, paroxetine is available virtually everywhere for $4 for a bottle of 30. How much does Brisdell sell for? More, yeah, more. $170. $170. And I picked this example because it's kind of, I think, almost amusing. But it's not really amusing. You can pick, there's dozens of the, you pick a drug, right? Our generic drugs are perhaps cheaper in general, although that seems to be changing. So pick a drug, pick a country, and we're, a lot bigger. So these aren't all to the same scale because of $4,000 drug in it, but the same ratio. And it's not just about the drugs, right? We spend outrageously more for CAT scans, for appendectomies, for normal spontaneous deliveries. We spend a lot on everything. And the procedural stuff includes hospital and physician charges, so internationally. So if you talk to most Americans, they kind of get that this is a problem. They understand that Medicare is legally prevented from negotiating the prices of drugs. Did you know that when Medicare Part D was passed, the Congress said, Medicare, you can't negotiate the prices of drugs. So that's part of the issue. And most Americans get that that's not a good thing. Again, crossing party lines. It doesn't really matter what party. And for the other non-pharmaceutical things, we're going all around the world. Almost 1 million of us are now doing medical tourism for the kinds of stuff you would think you would be getting in the good old US of A. And we're going to countries that are maybe surprising, that we're choosing to pay to go to these other countries. So my message here, of course, is that we can do better than this. So why are our prices too high? Price, I just sort of tried to compel you about. Is it because we go to the doctor so much? Is it because we're just utilizing so many services? Well, here's data. There we are. And there's these other countries going to the doctor a lot more than we do. We don't even have that many doctors compared to a lot of places in the world. We're not terrible at it, but we are low compared, but we lead the world at this. We lead the world at this. Right response. Okay. So if you do the arithmetic from the National Labor Relations Board, we realize we're paying the insurance industry primarily to tell us what we can't do, primarily to tell us which doctors we can't go to, which hospitals we can't go to. That's their core function. And I worked for many years doing that, so trust me, that is what we primarily do. Anyway, if you add up all of the people in a hospital working in billings and accounts receivable around the country, add up all the FTEs, billing and accounts receivable in hospitals, and compare that to the number of beds in hospitals, there are more people working in billings and accounts receivable, full-time equivalents, than there are beds. So every hospital on average could put someone full-time at the foot of their bed just to deal with their bill and then have a whole department left over. In Canada, I believe this is Toronto Children's Hospital in Canada, their billings department is 3 people, 2 of whom are dealing with Americans who stumbled across the border. So we spend a lot on this. This adds up to a lot. By this analysis, and there are others that have somewhat different numbers, typically actually lower numbers for clinical care. By this analysis, administration of health care in our country eats up more than 1/4 of it. And of that 1/4, the stuff that the insurance companies pay for as their administration is the smaller portion. Notice, the private insurance administration is smaller. Most of it is the stuff that you and I, as physicians, and the hospitals have to pay for. The average physician has something like $85,000 or $90,000 of office staff doing nothing but managing the insurance functions. The insurance industry has downloaded the cost of administering insurance onto all of doctors in hospitals. We spend more as doctors in hospitals on the administration of insurance than the insurance companies do. That's just breathtaking to me. So this is a past president of our organization, Deborah Richter, one of the leaders at getting Vermont healthcare single-payer thing as far as it did. And she said trying to save money by keeping patients out of the hospital is like trying to save money on schools by keeping kids home for the day. So it doesn't really work that way, right? Because we've already built the burn unit. So anyway, before we get to the solution side of this and the ACA, if I could have your 4 classmates go pass out these sheets. We'd love to have you give us your contact information. 2 things about the sheets. First is on the right-hand side, pre-printed, there's a column that says need PNHP speaker. So if you like this discussion and you think there's other audiences that could use this discussion, a church group, another school, something your parents are involved in, something your neighbors involved in, check that box and someone from PNHP, my friend probably Tom Flanagan, will reach out to you and figure it out. And we can keep you anonymous if you just want to give us the lead, or we can, so there's that. And then on the far right corner, just to the right of that, we've added in SNAP, SNAHP. So put a check next to the side of all the columns under the SNAHP thing if you want your classmates to get a hold of you and get you connected with the student chapter of this organization. And then, of course, be sure you get our little nifty handout. So there's that. Anyway, the Affordable Care Act. Have you heard of the Affordable Care Act? So true disclosure, I retired 5 years ago. I thought I would buy my own health insurance because I was 56 at the time. I just buy my own insurance. I have 2 letters from 2 different insurance companies declaring me as uninsurable, one from a company called the Golden Rule. There's irony for you. Because I have hypertension. So I'm uninsurable. So I retired and I took a part-time job to get insurance. Because I was mainly volunteering in free clinics, and guess what? When you're volunteering in a free clinic, it doesn't come with benefits. So I took a part-time job in a nonprofit so that I could, it's kind of crazy. So then the ACA kicked in, and now I, of course, am able to have insurance because of the ACA. So full disclosure, I'm a little bit biased probably by that fact. So there are some good things in the ACA. We have wider access to health care. It is literally the first time we've ever had a legislative commitment to universal health care in the country. We didn't achieve it, but it's the first time we've had that. There's massive reforms of the insurance industry, all kinds of things like letting me have health care, like keeping 26-year-olds covered. So there's all kinds of things on that I'm assuming you know about. Medicare, you've been hearing rumors that the ACA is destroying Medicare. Medicare is actually dramatically stronger than it was without the ACA. The trust fund extends longer than it did before the ACA, so we can talk about that in more detail if you want. And if you don't live in Missouri, it actually provides a lot of help to low-income folks getting access to health care, but Missouri has not crossed that Rubicon as yet, and that's a whole other discussion we could have. The problem with it, in my mind, is that it strengthens the insurance industry. It was written primarily by Liz Fowler, as I understand it, who was from WellPoint, one of the country's largest insurers. And after she wrote most of it, then she went back to the insurance industry. So the insurance industry literally wrote the language in most of the Affordable Care Act, and it, of course, is insurance industry favorable. And then it creates problems as a result of that. You know, we still have these lists. Insurance companies still tell us whom we can and can't go see. It's increasingly hard to maintain independent practice, and so more physicians are now employed than were not. That pattern started before the ACA, but it certainly didn't get improved by the ACA. There's all of these alleged pay for performance, value-based things, and I'll just tell you one little piece about the myth of these pay for performance pieces. There's a Cochrane review. Cochrane is this international collaboration that's probably the best non-biased way to look at meta-analyses, and the Cochrane group looked at pay for performance, you know, the pay doctors more to do the right thing, and they concluded, after looking at all of the data available about 2 or 3 years ago, that there's no evidence that these things work. So maybe this is a good thing to have these value-based initiatives, but what I submit to you is we are rolling them out to every practice, every group, every physician, every hospital, and they really are still in the alpha-beta testing phase. So there's probably no reason to expect that those things are at this point mature enough to create the kind of value that we're all hoping they could. And then it's incredibly complex. So that's really all I want to say directly about the ACA. But how do you do healthcare around the world? We can learn from these other countries. I don't think there's any system exactly in place in another country that we want to adopt, but we should look and see how they do it. And for the interest of time, I've reduced this to three models. First, there's what's called a national health service. A national health service. And this is a service. This is where the government actually provides the service. So you pay your taxes, and then so it's publicly funded, and then the government, England for example, directly employs the physicians, right? Directly owns the hospitals. This is how they do it in Great Britain. This is how they do it in the VA. That is, by definition, socialized medicine. By definition, because socialism, as you recall from your econ classes, socialism is defined as the government owning the means of production. So that is socialized medicine. There's reasons to think that might be a great way to go. That's not the way I personally want to go. That's not the way my organization is advancing, and I personally think that the country would never go that, or is nowhere near close to wanting that. It would get no traction. I say that's a relatively extreme way to transform a health insurance industry, and it's not what I'm here talking about. I am not here talking to you about socializing medicine in the sense of government owning the means of production. There's another equally extreme model, which is what we have today. So it's the mixed funding, you know, it's partially government, partially, you know, it's all this cockamamie stuff. And this is, I submit, what causes these problems. There is, however, a conservative model stuck right in the middle. National health insurance, not service, insurance. Just talking about the financing of it. Just talking about the insurance. Because guess what? Nobody's getting out alive. We're all, no matter how healthy you are today, there's going to come a day, I hate to break it to you, when you're going to need your own access to health care, and at that point, you're going to want the best access to the best health care, and we need, so the insurance function. So it's publicly funded, right? You pay your taxes. It's privately delivered. So just like Medicare is, you have physicians on their street corner or in a group practice or what have you. Publicly funded, privately delivered. It is how it's done in Canada. Canada calls their program Medicare. We liked that word. Lyndon Johnson liked that word, and he took it. So our program is called Medicare because we took the word from Canada. So that's how that works. It's a free market solution if you think about it. It's not a free market for the insurance function, but we all need good insurance. It's a free market for the delivery side, because then physicians are competing against physicians. You have to convince me that you're the doctor I want to go see. That hospital has to convince me that that's the place I want to go. It's a free market on the delivery side, driving towards perhaps lower cost, but certainly towards better outcomes or patient satisfaction. I don't know. It's a free market application to the delivery side, but yet it kind of homogenizes or gets rid of the insurance functions, which, as I said, are just to keep us from paying, to keep us from doing things. So there's a legislation in Congress, H.R. 676, co-sponsored by Lacey Clay, sponsored by John Conyers from Michigan. It's got about 60 co-sponsors, and it basically spells this out. Tomorrow, I recommend you go home and you Google H.R. 676 and read it. It's 30 pages, it's double-spaced, it's big font. You can do it in an hour, maybe 2 hours, and it's not going to pass the way it's written. It needs more meat and potatoes on it, but it gives you a strategic solution to everything that's flowing through your head about why this maybe isn't such a good idea, because it is a good idea, and there's a lot of thought behind how that works. And there were a lot of physicians, actually, who had a big voice in drafting this. So it just says really two things. It just says improve Medicare and give it to everybody. Improve Medicare. There's a lot of flaws with Medicare. It doesn't cover things that need to be covered. There's gaps. It doesn't cover my sending a diabetic to a nutritionist for a consult. There's a list of many things that it doesn't cover. There's significant financial barriers. You know, there's copays and deductibles, and at the end of the day, because of that, most seniors, if they can afford to, if they have Medicare, they choose to purchase a supplement or a wrap, and those things enhance the enhance the benefit design and eliminate the financial barriers for the most part. So seniors buy that. So we know what's wrong with Medicare, you know, as an insurance product. People have already, there's a market that's established those. So embed those things into the core offering of Medicare. We should all have those things. And then if you do that, there's really no need to have supplements or wraps. And H.R. 676 says an insurance industry can still exist, but it cannot duplicate or supplant the things that are in the core offering. So if they want to offer something else, if they want insurance for cosmetic surgery, or I don't know what. If they want something else, they can sell that. And around the world, that happens. Around the world, almost all single-payer countries do have a niche for private insurance. So it does exist almost everywhere. But it represents less than 5% of the spend in all those countries. So it exists. It's not a big deal. You don't have to solve this problem. But it's pocket change on a national budgetary planning basis. So that's what improving Medicare means, and then give it to everybody, including Congress. You know, give it to the president, give it to Governor Nixon, give it to Senator Rob Schaff, and he'll love it. Yeah, give it to everybody in the United States, you, me, everybody, because if everybody is in the program, then the government is not going to be comfortable disrupting it and hurting it, since it's their spouse, it's their parents, it's their kids who would be complaining, why did you do that to my insurance? Plus, it's way cheaper to administer if there's one program, and I'll show you data about that in a minute. Then you would roll up all the other programs that we have in the country, and there's lots of them. You wouldn't need these state-based programs like Medicaid, because it would be just one payer. So I told you I come from a financial background in part. Here's how it works. There's the detail, the granularity to it. The red box is smaller than the green box. So this particular analysis I'm going to show you comes from Professor Jerry Friedman. He's the head of economics at the University of Massachusetts. There are maybe a dozen or 2 dozen or so such analyses done by different economists making different models, different assumptions, and they come out with different numbers. And sometimes the green bar isn't as big as the red bar, is bigger here. The green bar is never smaller, usually significantly bigger, and sometimes more large. So at any rate, nobody serious is arguing that we can't afford to do this. The people who make that statement are only looking at the red bar. They're only looking at the new costs. And this was just a week and a half ago on the front page of the Wall Street Journal. Somebody did it. They were arguing that this program would cost so many trillions of dollars, without paying any heed to the right side of the spreadsheet. And that's just, so what are these elements? So first, you got to pay more for Medicaid patients, right? If we only pay in Missouri about $30 for a visit for Medicaid patients, we don't get very many physicians willing to see Medicaid patients. So you got to pay on par. I don't want to have to do, as I do today, an assessment of the economic value you represent to my practice before I let you in my door. And I got news for you. You got to do that, because you're in a retail business, and if you bring in a whole lot of people for whom you're only going to be getting $30 for the visit, you're not going to be able to keep your overhead up, which we'll talk about more in a moment. I'm going to show you income numbers near the end of this for Canada versus the United States. So there's that. We got to pay to cover the uninsured. Again, the same story. We have to include them, and then they're all going to start doing stuff. Utilization would go up. Perhaps a good thing, perhaps a bad thing. I think it's a good thing, but at any rate, that's what a reasonable estimate from the University of Massachusetts says it would cost. You can't stop there. You have to look at the savings. It's, you know, it's not an outrageous request. First of all, the government would only have one program to administer instead of a couple dozen or so. I'm not sure how many. So there would be one program. There would be savings, modest savings, $23 billion. The insurance administration, the health insurance industry would be a tiny fraction of what it is today for obvious reasons. There's savings there. And then the administrative cost to providers, again, notice that the administrative cost to providers is bigger than the administrative cost of health insurance administration internally, and this is a totally different person doing this analysis. And then lastly, you could negotiate prices of drugs like Brisdell or what have you. And if you did all that, this comes, by his analysis, it's about a $300 billion savings while providing health care to everybody in the country because of simplicity. I'm going to skip the individual piece of this, but let's go to this interesting experiment that happened. You may not have noticed it, but it's been happening since before you were born, and I say it's time to stop this experiment. So you may not realize this. Before 1971, Canada and the United States were almost identical in terms of health care systems. Almost identical. The Canadian healthcare system was spending almost the exact same amount that we were as a percentage of GDP on the same cost trends, and I'll show you that. And their outcomes were almost identical. They were living almost 1 year longer than we were. So close, right? And then in 1971, President Richard Nixon signed into law the HMO Act, right? Ostensibly to reduce the cost of health care, because we were on this trend that nobody liked. And then at the same time, Canada started this a few years earlier, but in 1971, Canada fully implemented their national health insurance, their single-payer model. So we have a fork in the road, right? Canadian healthcare system went towards a national health insurance. America went towards managed care and more private insurance. And what happened? Well, here's our cost as a percentage of GDP, starting down there, and now we're up around 19% or so. And then there's where Nixon signed the HMO Act, and it's hard to see any impact on the cost trend. There's Canada's cost trend. Notice how similar they were before 1971. And now they're about half. Now they're about half of what we spend. They were the same. Now they're half. And unmet health care needs. We have about 14% of Americans who say they have an unmet health care need. That number is about 20% lower in Canada. They have fewer people who report an unmet health care need. Most of our unmet health care needs are not from waiting lists or because of services being unavailable. 1% of Americans say they have an unmet need because of a waiting list. Of course, you have to get on the waiting list. If you don't have insurance, you're not on the waiting list, but there's that. Cost is the biggest reason why Americans have unmet health care needs. That's not a surprise. And then there's a smattering of other things. In Canada, it's the waiting lists. It's the waiting lists. They have services that they don't have, and so they often have to send them here. That's true. And they have waiting lists. And you've all heard those stories, right? Understand that those waiting lists are for non-emergent things, and I'll show you some proof of that in a moment. So the waiting lists are for the MRI of your back, for example, and that's pretty annoying if you're the person with back pain, but it's not life-affecting. And remember that they spend half of what we spend. So 1% from cost. It's not perfect in Canada. For example, there's no drug benefit unless you buy it, so it's not perfect. And then a smattering of other things. So, okay, so they have about 20% less unmet health care needs. What does that mean for life expectancy? So here they were, as I showed you, living about 1 year longer than we were, and now they live about 2.5 years longer than we do. So I would say it's time to stop this. The IRB needs to call off this experiment, because we have one arm where people are living 2.5 years longer and spending half as much and having 20% less health care needs, and we have another arm that's a little bit different. So it's time to stop this experiment. So physicians get this, right? We all know about physicians who are leaving Canada in droves. I'll bet you any of those physicians you know, or most of them whom you know, who are from Canada have gray hair, because for the last 10, 15 years, Canadian physicians are re-immigrating, I think I said that right, are returning to Canada. And American physicians are going to Canada the last 10 or 15 years. And why is it? Well, I only have this data for family medicine. I didn't pull it for every specialty, so sorry for the narrowness of this data point, but it's probably the same everywhere. Here's how an average week is for a family physician in Canada. I want to particularly call your attention to that they spend less than 2.5 hours a week working on non-clinical, not medical records, working on non-clinical administration. It doesn't go away, but it's less than 2.5 hours a week. Canadian family physicians, less than 2.5 hours a week. Remember, I told you that we're unhappy people, right? Here's part of the reason, and that's not building right at all. Sorry about that. At the end of the day, it's because we spend between 8 and 12 hours a week on administration, and those of us who spend 12 hours a week of administration are the least happy. Those of us who spend between 8 and 10 hours a week on administration are the most happy of physicians. There's a stratification between 8 and 12, and compare that to 2.4. So there's that. What about income? I promised you I'd show you income. Here's family physician incomes. Here's physician incomes, a somewhat random selection of specialties in the United States in 2013. And then here's Canadian incomes, same year. I'll just pause there for a moment. But wait, it's worse or better. I told you the average physician in the United States spend about $85,000 to $90,000 a year on administrative costs of managing the insurance industry. Overhead, right? Big deal. You get to keep more of what you take in. And the bugaboo about physicians getting involved in government is typically about malpractice. So think about it. The main reason people sue is because something's wrong and they want a way to cover the future cost of medical care. So if the future cost of medical care is something that they have and nobody can take away from them, the biggest reason to sue you disappears, and when they do sue and prevail, the biggest portion, more than half of the judgment against physicians, is to cover the future cost of medical care. So that goes away. So at the end of the day, malpractice in Canada and in every other single-payer nation still exists, right? It still exists, but it's not the political issue. And so here's a doc whom I don't know from Wayne State in Detroit who moved recently to Ontario, and he points this out. According to the Missouri State Medical Association, the average physician in Missouri has over $200,000 in bad debt, in accounts receivable. Over $200,000 of things that they did services for that nobody's been paying them for. Over $200,000 of that, most of which is averaging over 12 months in arrears. Goes away in Canada. So most docs get this, right? If you look at, if you do surveys, the majority of physicians, not the vast majority, this data is from 2008, and I think it's probably more in favor of what I'm proposing now, but the majority of physicians, it's more in some specialties and less in others, but nowhere does it go down to 5 or 10%, right? Even those specialties that are currently reimbursed at the highest rates, so maybe a little less inclined to take this risk, perhaps, and who have the less ongoing relationships with patients where, you don't get to hear the stories over and over and over again from our patients about how bad it is without health care. I think that's how this divides out, but I don't know. So we all and overall, well more than half. So have this conversation with your colleagues and with your friends and such. And most Americans actually get this. I opened by showing you about the volunteers. This is not about single payer. This is about Medicare. If you ask Americans overall, do you think we should mess with Medicare and cut Medicare? Most Americans, 80% of Americans say, no, don't mess with it. It doesn't matter your party affiliation at all, even Tea Party folks, for what that's worth. Most people don't want you to mess with Medicare. It doesn't matter your income level, lower income, higher income. It doesn't matter if you're younger or older. It doesn't matter your racial background. Women, as usual, are a little bit smarter than men, so there's that. So I'm here basically for 3 reasons. I'm here because I don't think you're very free when you're living one disease away from bankruptcy. I'm here because I think this is by far the most prudent way to do this. And retiring at age 56, let me tell you, I am prudent. If you have another model that can accomplish the goal but costs more, we could, I guess, talk about it. And lastly, I was brought up on Leave It to Beaver. I was brought, when there weren't reruns, we raced home from school to watch it. I was brought up to believe that this is the best country in the world, and in many ways it is. I submit to you that we have many of the world's best doctors and nurses and hospitals and such, because you have to be the best doctors, nurses, and hospitals to survive in the chaos that we've created. But we do. But yet, I'm here showing you slides about how other systems work better, and I want them to show slides about how our system works better. So last thing to tell you about is the most exciting thing in my mind. This has just exploded in the last 2 years. I've been involved in PNHP, Physicians for a National Health Program, for decades. But the last 2 years, there's been this amazing explosion of the student arm, this amazing explosion. So they're a rowdy bunch at times. They're a very studious bunch at times. They're a very social bunch at times. And they're very professional most of the time. So there's that. And I've got a 1-minute video I want to play for you that they created, students created.
This is Students for a National Health Programs conference that serves the purpose of invigorating the student body by bringing together medical students and medical professionals and think creatively about the ways that we can expand this work across the country.
We take this oath when we start medical school to do no harm.
I really believe that healthcare is a human right.
It's our responsibility to be a voice for our patients.
Last year, we really made a commitment to start building our movement.
As a future medical professional, I thought it was at least my duty to fight for single payer.
I chose this path in life because I want to become a doctor who treats people based on their medical need, not their ability to pay.
Single payer is the only solution.
It just makes economic sense.
To really change the quality of care in the United States is to go to a single payer system.
Since the last SNAP Summit a year ago, we have 10 new chapters.
I really became inspired by the other students in the organization, and that motivated me to start a chapter at UIC.
If we don't speak out in support of Medicare for all, we are actually doing harm to our patients.
It's a lot easier and it takes a lot less energy to do the right thing every day.
So there's that. Anyway, be sure you get your name on our little list that's circulating around, and we'll stay in